All right, so an osteopathic musculoskeletal exam for the hospitalized patient. Do I just hit space? All right, so the learning objectives today, we're going to recall our osteopathic tenets, the definition of somatic dysfunction, because yes, I don't care how far you get in your boards, it is always on your boards. Reviewing the differences between chronic and acute tissue texture changes, and going through the components of the musculoskeletal examination. Okay, so again, performing this muscle examination as part of your integrated hospital exam history and physical, because a lot of times you get to the point that it depends on what rotation you're on, whether you put your osteopathic hat on or not. Actually, it is the same hat. It may have different bills. You may have to spin it around to get the osteopathic bill of your hat, but it is the same hat, and it's easy to do. Easier than you might think. And then documenting the relevant findings. All right, the osteopathic. Again, the human body is a dynamic unit. The body possesses self-regulatory mechanism and self-healing. Structure and function are interrelated, and rational treatment is based upon these principles. So again, somatic dysfunction, impaired altered function of the related components, skeletal, arthrodial, myofascial, and their vascular, lymphatic, and neural elements. All right, so tools: history, physical exam, laboratory and imaging, your data bank or your differential, and investigative through processes. So we're going to focus on physical exam. All right, so integrating this physical exam into the standard of care examination, your basic examination. Obviously, you know, depending on what service you're on and what problem or what chief complaint they come in, alter how you're going to focus. You may not be focusing so much on someone with abdominal pain on the ENT areas, but still you need to cover them. But obviously focusing on whatever the problem they have, such as abdominal pain. Again, making sure we look at the body regions, targeting the high yield area. So again, key components of this. So the visual inspection of the spine and your TART findings. Again, tissue texture changes, asymmetry, restricted range of motion, and tenderness. I like to, think about this, just laying your hands on somebody. Even if you're using the stethoscope in between, oftentimes I've used a stethoscope to assess whether they're having tenderness in their abdomen by just applying a little more pressure on the stethoscope to determine whether they're having some abdominal pain before I start doing my superficial and deep palpation. Because it gives me kind of an idea, because, most people who, well, let's just say may not be above board, and that may be in there for secondary gains, they're not thinking that you're doing some deep palpation with that stethoscope. They think you're listening. So you can use that as an alternate tool if necessary. Again, you should examine them at least 2 positions, and I think that, has been modified. I'll have to get back to you on that one. Examination not always performed in one position. So, if they can't get up, or just say why. Just say what positions you examine them seated. Some people, it's a lot easier to examine them in a seated position, especially if they're sitting up and already eating. If they're laying down, and you have to wake them up, obviously you do it in a supine position. Not many hospital patients are in the prone. Lateral recumbent, but really not prone. And again, make sure that you address the somatic dysfunctions towards the chief complaint. Now, if you're on like an OMM service and you get consulted for a different area, then that's a little different focus. You focus on whatever they consulted you for. But as the straight intern, you want to make sure your osteopathic findings and examination focus on the chief complaint. So think about functional units and the requirements for health in that particular area. Progress from the least invasive to the most, and be effective and efficient. So again, you know, the roadblocks to this is that it's often an additional examination. Oh, I'm on with an MD, so I don't have to do these, yet I'm in a DO hospital. So, you know, if the MD doesn't want to sign off on your osteopathic findings, he can line through them. But you still have to do them as part of your osteopathic exam because you're in an AOA hospital. So, relative findings are not often understood. If you describe where it's restricted, they'll be understood. Takes too long. Now, I'll show you ways that you can be fast and effective. Requires elements of the H&P not used otherwise. No, we audit them. So if we audit them, then they're used. And oftentimes, you know, they may come up with alternate areas. Somebody might come in with a headache, having other problems elsewhere, so we start thinking of other areas. It's all connected. Your physician and attending having the most information, and all the information is critical to his treatment and proper care of the individual. So, not always embraced by attendings and residents. Yeah, kind of get over that. You know, just because someone doesn't do OMM doesn't mean they don't understand it. Remember, it's the philosophy that it's all connected. And then all of our attendings, regardless of their specialty, regardless of whether it's DO or MD after name, understand that it's all connected. So, changing position, it starts with you. Obviously, if you don't do it, it won't get done. So, make it a seamless part. You know, if you're going to do it, just make it part of whatever you do. Because like when you do your H&P and your review system should be almost like the Pledge of Allegiance. You know, you should be able to recite that in your sleep. You know, HENT, cardiac, pulmonary, all those particular areas that you have memorized. Why do you memorize them? Because if you memorize the spiel that you're going to give on the review of systems, it's easier to remember, and whenever they say something positive, it stands out in your mind. If you're jumping around all the time on that little card that we all have that reminds us, it's harder to remember. And after about 20 or 30,000 of these H&Ps that you will inevitably do, you will develop your own process and remember the order which you go in. So it gets easier with time. First H&P I did as a third-year medical student took about 3 hours. I was very thorough. I got it down to 30 minutes within a year. Because I wanted to be thorough. I wanted to do my best. I wanted to do the best I could for the patient. So you'll find ways to optimize it. So don't worry. Remember, if you put your patient before your pride, you will always do the right thing. So integrating these findings and other physical findings into a examination, treatment of both have distinctive advantages. Don't be afraid to use your skills. You know what, there's never been a rotation where I've had students that I didn't learn something from them. So, all right, so adjust the environment. You know, we have really good new beds here. I don't think we have any of the old beds anymore. Do we? Remember the beds that we had you train on in second year? I'm pretty sure we got rid of most of those. It's really nice. They all have push buttons. They all come up. So there should be no reason why you are down on your knees, hurting your knees or hurting your back. Get that bed up. Make sure that those railings are out of the way. What's the most important thing about a railing? That it's up when you leave. And that there are not 4 of them up. 4 of them up constitute confinement of a patient. So if there were 2 up when you got in there, make sure there are 2 up when you leave. Watch out for the lines, watch out for the tubes, especially when you're moving beds. Plugs come out. Don't ever pull out an IV. So, because the nurse will make you put it back in. Focus on the key areas. You know, for ribs, pneumonia patients, a very key area, abdominal diaphragm. You should focus on more than, 4 or 5 minutes to take you to complete this whole exam. If you keep it focused and you keep it a part of your process, you'll do it without even thinking about it. So and respect the patient's modesty. You know, have a blanket so that when you're lifting up their legs, checking range of motion, that you're covering up their privates. Again, hospital patients benefit from OMT. Treating those related somatic dysfunctions are a great benefit, even if they're axillary. You know, someone's got a heart problem but comes in with low back pain, we're often consulted for that, because you know what? If you're hurting in two places, if you can take away one of those places that you're hurting, that's one less place of discomfort that you're going to have. All right, primary goal is to return to health, optimize function. And again, should be performed the appropriate frequency. You know, typically hospital patients are seen every day. You don't need to be, you know, overly aggressive, you know, trying to do some HVLA or other techniques. You can be more soft, more gentle, do mild fascial release, soft tissue. Sometimes whatever that patient can tolerate, especially if they're post-surgical and you're working on iliuses or they're on a vent. You know, gentle rib raising, soft tissue, you know, just treating the sympathetics and parasympathetics. So modify your frequency according to the patient. Again, you know, minimum amount of duration. And again, it all depends upon what results in continued improvement. You know, there's some days we go in there, we ask the patient, you know, are they feeling okay? Do they want to skip a day? Or if yesterday was a little bit too aggressive, or sometimes they've had other treatments or other procedures where they're just really, you know, not feeling like it. We'll go ahead and skip a day. So again, making sure that we're doing the proper amount of treatments. Again, maximizing for their improvements. Couple their treatments with their surgical or medical interventions. Again, you know, oftentimes we do rib cage stiffness for patients with pneumonia, myocardial infarctions, low back pain, sacral dysfunctions with labor. All right, indications, somatic dysfunctions, pain, restricted range of motions, atelectasis, iliuses. We have a consult today for an ilius. Very common complaint that we get consulted for. Poor feeding in neonates, and then other dysfunctions. Okay, so contraindications, again, cancers, not a direct one. Always some question whether you do lymphatic pumps. You know, pretty much just try to, oftentimes just techniques in that particular area, you know, use your head. Bone dysfunctions, vertebrovascular disease, you know, no HVLA, you know, kind of avoid the great articular one. And then, you know, drains and vents around those particular areas. Again, the sicker the patient is, the less dosing, the more frequency. So, you know, doing more but gently allows them to recover faster. Allowing time for the patient to respond. Again, sometimes we take a day off, we give them a day off. Oftentimes, as patients start to get better, they get transferred to swing. We may just see them every other day. Always err on the side of not overdosing. So don't overtreat. You know, the phrase of find it, fix it, and leave it alone. It's like everything else. Once you get things rolling, just kind of let the body do its job. So, and don't waste time on insignificant areas. So again, any questions so far? Okay. So again, disease in abnormal bodies just as natural as health in all their places. All right, so acute somatic dysfunctions. So onset most often related to injury, warm, moist. You know, you've all had a sprained ankle or something like that. You know, it kind of flares up, gets kind of puffy. You know, no trophic change, more of a boggy, increased sensitivity, spasming, local inflammation, sharp, kind of cutting type pain. Again, increased sympathetic response, minimal vasovagal. Long-standing, kind of stale, kind of ropey. You've all felt, you know, some of the patients who have had long-term back problems, they just feel as tight as a rope. They're not moving as well. kind of congested. I like the ropey scenario. It just kind of gives a better feel of what those muscles kind of feel like. Sore, more of an achy, more of a deep, increased sympathetic activity, and oftentimes you can have, particularly people with thoracic back pain, always thing you want to think about is what refers to that area. You know, especially acid reflux, abdominal areas, heart, lungs, you know, start thinking about what refers to that area. So again, somatic dysfunctions, areas we look at, the cranium or cranial areas, the OA, AA and the cervicals, so as far as our parasympathetics, thoracic inlet. You know, as the older we get, the more our shoulders seem to come forward, the more we impinge upon our thoracic inlet. The heavier the bags we carry, the more we hold our shoulders up. So, again, ribs, first ribs, and then our bucket handle and pump handle type dysfunctions, clavicles, sternum. All right, so thoracic problems, you know, type 1 to type 2. Usually the type 2s, remember the type 2s rotate and side bend to the same direction, have a flexed or extended components. Those are usually more severe than your normal type 1s. Type 1s, you have at least 3. They rotate and side bend opposite, and they usually occur in the neutral position. So, abdomen, almost always find somebody with either hiatal hernia or GERD will have some sort of epigastric myofascial wall restriction. So look for diaphragmatic dysfunctions as well as your sympathetic tone, and in particular celiac ganglia. And again, your lumbar, type 1s and type 2s. All right, so anterior and posterior rotations of the pelvis. Again, the particular diaphragms and that particular restriction and pubic compression often occurs in pregnant women. Should be one of the things that we should be checking right after birth, vaginal birth, to make sure that it's come back and lined up. Often overlooked. Sacrum, I know everyone hates the sacrum, but the sacrum is not as hard as it seems. You just look for where it doesn't move, and you can document it that way, and then try to do something, and we'll talk about that a little bit later, to try to get it moving. Again, you can assess it from the side or up from the bottom. Usually the side is the most easiest. So again, extremities, you want to be thinking about the AC, the glenohumeral joint, the rotator cuff, elbows, and the wrist. Lower extremity, hip range of motion restrictions, knees, different special tests, and the glides of your feet and ankles. So, again, probably the thing that you will always, always, always find on your boards is the whatever refers to the sympathetic area. This is the most common on boards. They usually, you know, won't nitpick you. Oh, well, this is in, you know, 5, so therefore it can't be the neck. We usually try to stick stuff right in the middle so that you don't kind of, you know, nitpick, because there are other references. So, on board examinations and questions such as that, you're going to have something in the mid-range to make it easy to differentiate. So, but again, someone comes in with thoracic or upper lumbar pains, always think about what refers to this area. At the very least, it's a history question that you can add to your review of systems. Oh, well, they have pain in this particular area, so I was asking them about their acid reflux, heartburn, or whether they had any colon cancer, constipation, other things like that. So, all right, so again, appropriate level. Paraspinal muscle spasms, almost always. Anyone that's ever rotated with me, I'm sure you're probably sick to death, and I know that you know how to do soft tissue and muscle inhibition, but why would I have you do that in addition to keep you busy and not fall asleep? is that because I want to make sure that those paraspinal muscles, both in the cervicals, thoracics, and lumbar, are effectively treated. Oftentimes that can help down-regulate the sympathetics and parasympathetics. So we also look for rib restrictions and ganglion. So again, let's think about the parasympathetics, because that's why I like you to do soft tissue in the cervical and head, parasympathetics. And oftentimes, depending upon what the problems are, we may have you do some soft tissues in the sacrum. So again, look for condylar depression, mastoid type suture restrictions, and focus it to the complaint that you have. Headache pain, neck pain, but you can also just do soft tissue techniques and inhibition on these techniques as a way to stimulate their parasympathetics. Do some sacral rocking. All right, so again, we have a visceral referral pattern again. So when we think about the lungs, we're thinking about the tight paraspinal muscles, edema, facilitated segments. Facilitated segments is a fancy word that it's being stimulated from both ends. So you've got, lung issues that are causing referred pain back to that particular region of the spinal cord, but you also have somatic dysfunctions and arthrodial or joint type problems that are generating signals going to the lungs. So you got this vicious cycle going on, and part of OMT, and in fact the initial research into OMT started with these facilitated segments. The research in that in the 50s with Gore and trying to think of what else the other guy's name is. Dooley. I think I missed that. But anyway, good trivia question. So the facilitated segments part is what treating the spinal cord does to decrease that vicious loop cycle. So what you're doing is you're decreasing the output from the spine into that particular area that's already having problems. So again, also the impaired or muscle function in the sternocleidomastoid and scalene muscles. Oftentimes is appropriate with accessory or axillary muscle use for asthmatics or people with COPD. So again, you want to decrease these responses or stimuli, and by decreasing them, you have decreases the output of the things that are increasing the other problems. So, or another way of saying that, just go ahead and decrease the motion in that particular, the decreased motion in that particular area is causing increased problems. And before I stumble on that again, I'm going to move on. All right, so hospital exam. All right, so it's what? You've been into this how many days now? Interns? Yeah, almost a month. And how many more months you got to go? 11.
It's 48 weeks.
Thank you very much. Yeah. I knew someone would have that down to the day. I appreciate that. Because, it's kind of like an overseas tour. You know when it starts, and you know when it ends. All right, so ideally you want to examine them in two positions. Not always possible. You can get in there with one, that's fine. Just, if you're only going to do it one position, make sure you document why, they're on a vent or post-surgical, or they just frankly don't want to move. Position is unique to, diagnostic challenge, but you know what? You're osteopaths. You can feel things. Your ability to feel things is more adept than a lot of people, especially on the area. There is I found this very unique. There's a surgeon who does, he's a urologist, and he prefers to take out the prostate. When someone has prostate, he prefers to take it out manually. Because now they have a big robot that can do all this. Kind of like laparoscopic. He prefers to do it manually because he can feel the surrounding tissue to know whether he needs to go further on the margins. I was really impressed to hear about a man, particularly a non-osteopath, saying how important it was to be able to feel the tissue. He decides whether he's going to take out additional lymph nodes or not based upon how they feel. That's impressive, you know, on anyone's skill level. To develop that skill to being able to feel and to use that in their clinical judgment. All right, so, you know, proper positioning, you know, your hands under the patient. We always go underneath the linen, you know, just lift up the linen, slide through. The hardest part is when you put the gloves on and then try to slide underneath. So oftentimes, you know, we don't put gloves on unless we're going to make direct body contact, unless of course they're under precautions. Again, you know, you're good enough that you can feel through things, you know. If the pad's in the way, just move the pad out of the way, but feeling through linen isn't that challenging. So palpating is, you know, multiple positions, may not always be necessary if you can just get them in the seated, you know, or just laying down. And we went over some different techniques today of assessing the the lumbar spine in the supine position by using the visceral and the mesentery of the abdomen to assess. And it was a crude assessment, but we found out which way it liked to side bend quite easily, and we used that in our documentation. All right, so, you know, palpating a supine patient, you always want to look at the head, neck, and first rib, thoracic. So usually from the head of the bed, sliding yourself down. Lumbars and thoracics, more easier from the side. Just cup your hand under the both sides of the transverse processes and just push the body back and forth. You know, your fingers and thumbs are going to be able to feel as that processes are cradled between your hand and your thenar eminence. You're going to be able to feel which motion it is. I don't expect you to have an exact diagnosis. I expect you to have something. You can always find a tart find. It's restricted. It doesn't like the side bend. It doesn't. I just want something. The better you can do it, the better you're going to be. But sometimes, you know, finding something is better than finding nothing or saying I couldn't find it. So again, cup your hands under that, roll, push back and forth, gently assess up and down. Stuff that people that have gone to KCOM would have done in their second year. So again, sacrum, I usually like to come in from the side and then just push up on the inferior and superior aspects, and then I can slide further underneath and assess further. If they're having constipation and you're treating it very effectively and they end up with diarrhea, you know, we have gloves. You know, we used to have gloves that go all the way up to here if you needed them. But so don't be afraid to get in there and assess that area. You know, particularly that ability to rock the sacrum and get it moving again is a very important process that helps the parasympathetics. Remember, your goal is to get the patient better and get them out of here as soon as you can. So again, you know, your ASI compression test. Yeah, it's a little hard when you're on a bed because the bed likes to give, but you know, if you take it, get it to the barrier, you can assess it and be able to figure out, you know, where it doesn't like to go, whether there's some restriction, and then just give it your best shot. Oftentimes we use more of a motion testing, kind of a twisting motion. Oops, there we go. Ribs, very easy to assess. You know, you're already in there listening to them. You know, just put your hands on both sides and have them take in a deep breath. If they're on a vent, you know, feel for the motion when it occurs. Again, bucket handle, pump handle. You know, so more of the bucket handles, more of the upper, the more chest-based, you know, versus the bucket handles more further down on the sides. And, you know, just because someone had a lung resection, it's more important than ever to make sure that you know, that the side that is still intact is working. So that's really important. So make sure you're assessing that, finding any dysfunctions in that area. All right, so defined health should be the objective of every doctor. Anyone can find disease. Again, you know, my kind of slant on is that as long as you put your patient ahead of your pride, you know, you can never do wrong. and you're always going to feel good about what you did that day. You're going to get yelled at. That's kind of part of the process, you know, and you just got to smile and say, yep, but I put the patient ahead of my pride, and that's why I called you at 4 o'clock in the morning over something you may have thought isn't that significant. It was significant to me, and I thought it was to the patient. Because you don't want to get called at 7 o'clock in the morning when you're half asleep and you don't even remember the patient's name. Why did you give this patient this? Now I can't take him to surgery. Well, I called the medicine person. They said to do it. So you're going to get yelled at. So always make sure that before you give something that will prevent somebody from going to surgery, you check and see if they're going to surgery. You know, like Lovenox or something. So, anyway. All right, so interstitial cystitis. So again, when we think about those particular areas, the objective here is to make your ability to find osteopathic findings part of what you're looking for when you're doing the physical exam on this person for this problem anyway. You know, let's not just have you do a head-to-toe thing looking for random stuff. Let's focus it on this area. So let's think about this. So they come in with this. So what are you going to look at? 10 through 12. Start looking. Focus your TART findings in those areas. If you don't find any in those areas, hey, indicate. Check those areas. No TART findings. That's good. You know, having something, you know, is better because it gives you something to treat. But checking it and having nothing there is just as good in my book because you said there's nothing there. So again, sacrum, making sure that there's good sacral function, rocking back and forth. And you know, the easiest thing to do, you don't need to have them move or bend because remember, the sacrum moves when you breathe. Okay? When someone takes in a deep breath, the base of the sacrum goes posteriorly. Now when they arch their back backwards, it goes anteriorly. It's kind of something to remember for boards and mechanics. But just have them take in a deep breath and make sure you're on the sacrum. You can feel it. One side may be moving more than the other at the base. That's an assessment, right? And of course your lymphatics, you know, your thoracic inlet, abdominal diaphragm, pelvic diaphragm. You know, and you know, when you're checking the pelvic diaphragm, make sure you have proper chaperoning, okay? All right, so chronic constipation. So again, we're looking at the same area. So we're going to be looking at the paraspinal muscles in that particular area, our TART findings, the collateral ganglia. We're also going to be looking at the paraspinals because you know what? Oftentimes you've got to stimulate the rest and digest to get all that moving. And once you get that moving, nursing does not want you to come back. Once you get all that, because you know, internal medicine or family medicine is going to be treating it chemically, and you're going to be treating it structurally. And once that gets going, it's flowing. So again, you know, always think about your lymphatics and your vascular drainage, particularly your thoracic inlet, abdominal diaphragm. Think of your mesenteric lifts. It's really easy. So just start at the cecum. Pull the abdomen, everything towards the belly button. Why do we start at the cecum? It's kind of like you don't yell fire until you make sure that the fire doors are open. You don't want any blockage in that area. All right, so big thing, pelvic, peptic ulcer disease, you know, acid reflux, heartburn. I can't tell you how many times I've had people that come in with thoracic pain in this region. At the very minimum, I indicate that I've asked history questions about that. Acid reflux, heartburn, do they take too many NSAIDs? You know, what are the things? It helps me direct what's going on and what further opportunities I need to do. The sympathetics, you want to hit the OA. And so, and then again, you know, you want to check the thoracic. And these all give you key things that you want to check when people come in with these particular problems. Acute bronchitis, again, 1 through 6. You know, you want to check first ribs, anterior ribs, rib functions. You want to check the OA, find out what that is. Again, the thoracic inlet, abdominal diaphragm, treatment with rib raising. So again, Ed Douglas was one that originally created much of this. I've modified it a lot since then, but I want to thank him for his contributions. Any questions on that particular area? All right, so the objective of this examination was not to force you to do unnecessary exams on people just to get your points for osteopathic exam. It is to integrate in your mind that an osteopathic exam is part of your regular examination. It's information that you can use to better help your patient, you know, by helping them restore function, by restoring motion of their ribs and the abdominal diaphragm. Studies have gone on that shows that we can reduce hospital stays by helping the increased flow of the lymphatics and better respirate, particularly with patients, senior patients with pneumonia. And you know, you save hospital money, they make money. And patients get out of here faster, which means there's less opportunity for secondary infections. So I have 2 minutes left. I will take any questions. Okay, it doesn't mean you're done yet. It just means you have time for questions. All right, so a couple key point things is, and so when a patient comes in, think about those particular areas that refer pain to and check those areas. Check the sympathetics. You know, look for blockages. You're already listening to the abdomen. Feel the abdomen. Feel those particular ganglia. You know, depending on whatever else they came in for, you know, check those key areas. But always thinking sympathetics, parasympathetics, and those are key areas that you can examine. Document what areas you found, or, you know, areas that you checked and didn't find anything. And make sure you put it in your note. All right, 1 minute left. Again, you know, anyone here is highly approachable. Again, we do audit your H&Ps, and you know, this is we usually try to give this lecture twice because once it's kind of overpowering. Once you've done it a couple times, and don't be afraid to ask, you know, somebody, oh yeah, what else do I need to check? Because we'll be doing this again. Remember, focus on the patient, what they came in for. Don't make it a blanket type examination. You know, focus it, because that key information can help better get that patient out of here sooner. And now I am out of time. Thank you again for your patience. I appreciate your time. Please don't forget the valuable things that you have learned throughout school. It does make you a unique doctor with unique abilities, and people appreciate that. Not that our colleagues are any lesser doctors, but we have an additional skill set, and please use that. Thank you very much.